I'd like to invite Blair to come up. So Blair's a cardiologist by training, and he was our first... No. He's the first medical director of the Cardiovascular and Stroke SCN, or as I like to call it, the Stroke and Cardiovascular Health SCN. But Blair's now moved on, and he's actually as part of his role now, he's actually overseeing all the SCNs. And so we've invited Blair to give some comments on the SCN process and our involvement. So Blair, thanks for coming.
I'm going to talk briefly, a bit of a walk down memory lane for me. As Mike said, I was the inaugural medical director for stroke and cardiovascular health, rather. And so at the beginning, a little bit sensitive, being a certified knuckle-dragging interventional cardiologist, sensitive to that role. We brought stroke and cardiovascular together. I think it's no secret that, when we compare the cardiology world to the stroke world, analogies are always dangerous, asked Hillary Clinton. Canada, or rather, cardiology could compare it in resources to the United States and perhaps stroke to Canada. It's a more favorable, I think, comparison for stroke to Canada. The way we structure strategic clinical networks, bring that core committee together from the cardiovascular world, prevention world, right across the province, stroke world. When we looked at various data, I was proud of the fact that, cardiologists admitted we needed to do some work in the stroke world, and those were the projects that were prioritized and went forward to the Dragon's Den and ultimately were proven. We took two big stroke projects through, actually, to that Dragon's Den. I'm going to talk about one, Stroke Action Plan, that I'm very, very proud of. We also bought ERA, endovascular recanalization, through as well. Being an interventionalist, I understood that actually going up, looking at the artery and pulling out the clot sounded like it made a lot more sense than simply giving the clot buster and hoping that it worked. But Tom Noseworthy quite rightly challenged us and said, no, you need more evidence. It's not there yet. And so Mike Hill and colleagues really hit it out of the park with the ESCAPE trial and showed that it is superior to TPA. So now our challenge is, how do we get it into action? But I think it really shows how networks work, and again, proud of that. So this really is the story of Stroke Action Plan. So we've heard some great stories, and particularly from Shelley from Red Deer, about how successful her treatment was. But when I came on as the medical director, when our team was put together, we looked at the data of various diseases across the province. And one of the things that struck me about stroke outcomes, if you look at 30 days outcomes, I think anybody looking at this slide would say, boy, I hope I have my stroke in Edmonton or Calgary. But is that fair to the people of Red Deer, to Grand Prairie, to Camrose, to Medicine Hat, and all points in between? No, absolutely. And so when I think of the Stroke Action Plan, that's what's really all about. We've started as Alberta Health Services, one health system, I think a benefit. We realized we needed some local autonomy, so we went back to zones. But zones can't do this. It takes a provincial entity looking at the province and saying, this just ain't fair. We got to fix this, folks. How do we bring stroke equivalent care to the rest of the province? That's probably the difference. TPA makes a big difference. The Alberta Provincial Stroke Strategy made a big difference, planting those 12 stroke centers, making sure the maximum number of patients who warranted TPA were given it. But after that, after the TPA, after your emergency room visit, it takes tough, stubborn patients like Shelley and Ron, but also it takes that Stroke Action Plan. You need that swallow nurse sitting on the top of your bed telling you when it's time to swallow and when it's not safe to swallow. You need that physiotherapy, because if you don't, while the brain is still healing, if you don't get that physiotherapy at the appropriate time, you will not get the recovery that you need. So that's what we discovered in Stroke Action Plan. So we all know stroke is devastating. It costs a heck of a lot of dollar. Preventing one stroke creates amazing savings to the system. And aborting a stroke through TPA, or now endovascular recanalization where it's available, produces tremendous benefits, because it's costly when a patient has a stroke, has a prolonged hospitalization, a prolonged rehabilitation, and then it still leaves patients with significant rehabilitation patients. So how do we prevent it? How do we treat it aggressively? But we know stroke unit care is responsible for a lot of that, and we had it in Edmonton and Calgary, at the University of Alberta Hospital, at Foothills Medical Centre. The problem with smaller hospitals, if you don't have a big enough bed base to justify closing X number of beds for a stroke unit. So how do we overcome that? And that is basically the background of Stroke Action Plan. So basically, Stroke Action Plan was about developing and implementing well thought out national guidelines to establish stroke unit equivalent care for all stroke patients accessing 13 rural and small urban sites. So again, this project was focused outside of Edmonton and Calgary. Again, something totally different. And then where it was possible, because we know there was some early stroke recovery, the stroke team visiting patients in the home in Edmonton and Calgary was tremendously successful. How do we duplicate that in a rural setting? Don't have the volumes of stroke. So we said, why not use the same provider, that same physio, hire them in the hospital. It's hard to hire a 0.2 physiotherapist, but if we now have that 0.8 or 1 FTE because they followed you to your home, that might be a home run. So early supported discharge was also born in the larger centers, Red Deer, Camrose, Grand Prairie, Medicine Hat, and Lethbridge. It was a big project as far as project goes. We had 11 FTEs for the North Zone, over 15 in the Central Zone, 12 in South Zone, and then a provincial support team of 5 zones. You can see the number of positions. You can see the salaries and benefits. It's not cheap to have people do it, but I've shown you what the payback potentially is. So this was over a $4 million project that we had the benefit of undertaking. But there's something else interesting about this. How many people have been involved in a project that you have tons of project money, you do the project, but then operationalize this? Raise your hands. How many have been involved with that? I'll tell you, anybody in the Alberta Provincial Stroke Strategy, that was what it was all about. So when we presented this to Vanessa McLean, for instance, Smart Zone Medical Director in the South Zone, I don't want to be part of it. And he said, no, wait a second. If this works, if you send your people to the learning collaboratives, if we get the results we think we're going to get, we'll turn that money and those positions over to you at the end of the project. So it was not going to be like Charlie Brown and the football and Lucy pulling the ball yet once again. No, we were going to leave the football and allow the zones to keep the money, keep the positions, had to sign an accountability agreement at the end of the trial, though, so they couldn't take those FTEs off to some other need in the zone because we wanted it to improve stroke care. So how do we achieve success? I think it's actually masterful. It certainly convinced me. It was the first time I was involved in this type of spread and scale trial or project for the province. Basically, it's about acting, planning, doing, studying, the old PSDA cycles, but on a grand basis. So taking it locally, having you develop quality indicators, measuring yourselves, and then comparing yourselves to others when you met at one of the 5 learning collaboratives. And amazing progress was made over time. This, I don't expect you to read it, but it's an example of what we call a balanced scorecard. So you define the metrics. We sort of specified some critical ones, but we allowed the sites to define some local ones that they felt would help improve. You don't start at 0 because anytime you do something different, you can actually make things worse. So a balanced scorecard allows for measurement in the opposite direction, that things get worse. And then you celebrate successes when you actually do see things improve. You can celebrate successes. So you measure these metrics, you see how percent of times, and those things would be swallowing assessment, standardized order sets used in a center. So again, these don't sound like big things, but they make all the difference, because if you don't do the right things over and over again, you don't measure yourself, you won't get those optimal results that you need to get in order to improve the outcomes of stroke patients. We reported back to operations just how successful they were being, and that again was part of the sell function to operational leaders in the zones, that we're actually making progress. You are actually getting improvement in the process of care, and if you ask engineers, if you get the process right, the outcomes will follow. And so amazing success story. I think one of the big learnings for me is just getting the breadth, this is the advantage of Alberta Health Services. When you get Brooks talking to High Prairie or High Level, small centers dealing with equal challenges, how are you getting this done? Oh, we're doing this. Well, that's a brilliant idea. We'll do that too. That's part of the spread and scale, just bringing people together, the energy, the magic of people who want to make their care better, making it happen because they get a chance to interact. And why shouldn't we share the knowledge across this health authority that we've created? So we saw some tremendous improvements in the process of care. So standardized order sets improving from only about 50% to over 3/4. We got a ways to go, but that in a short period of time is a tremendous improvement. Rehab, so critically important for that brain healing. So we got to assess the patients. The earlier, the better. Once you lose that window, the disability becomes permanent. So time is very important, not just in the acute setting, but also in the rehab setting. So again, 3/4 to nearly 90%. Median length of stay dropped, and that's mostly because of the early supported discharge. So most of those, in fact, some lengths of stay reduced from the order of 11 to 14 to 5 days in some of these centers. What a tremendous improvement in the resource. And yet, if you're going to rehab from a stroke, isn't it better to do it in your home? That's where you're going to live. That's the important part. Swallowing screens, again, critically important. If you're not ready to swallow and you aspirate and you get a complication, one complication begets another complication. It's a real safety concern. Early supported discharge patients, we went from 0 in rural Alberta, because the program didn't exist, to 161 patients in 1 year. Stroke unit equivalent care patients per year, again, we didn't have stroke unit equivalent care across our non-Edmonton, Calgary-based institutions. Over 1,000 patients received stroke unit equivalent care. And long-term care admissions, tremendously costly. So this is a measure of the long-term disability of patients who could never go home, had to be discharged to a long-term care institution, a 28% reduction. That's a huge cost savings in and of itself. And this was the reward for the zones. We turned over those FTEs to the zones and the financial resources to the zones so they could operationalize these things. We didn't ask to find it. In a zero-sum game system, how are they ever going to find it? We would have lost this project and it would not have produced the sustainable results that we're actually seeing. On the SCN front, of course, we had central resources that went out, did the Learning Collaborative, the clinical resources. We can use those people now for other projects. We're focused on heart failure care and COPD care in institutions, transition of care. Well, those people really have built up an expertise that now we can move on to the next disease entity and make it better. So, a tremendous system resource. So funding follows good outcomes and data. So that was, the carrot for the zones to provide us with the data and to provide us with allow their staff to come to the learning collaboratives was because this would become available. So the initial funding put the site staff in place. We supported, trained, and set the sites up for sustainability. The innovation collaborative using the Institute of Healthcare Improvement methodology from the United States provided QI improvement, and we embedded stringent project evaluation because one of the things about the SCN, we just don't do projects and think they're going to be successful. We want to measure ourselves and prove that we're successful. Overall, SCNs, with our first $20 million investments in the SCNs in 2012, have produced a $44 million return on investment. What other things in the health system do we do that? But it's because we approach this best practices and create this sort of difference in the system. We talk about triple, now we talk about quadruple aim, and that the big parts of triple aim are patient satisfaction. But I would say, as a provider, if you know that you're providing better care, and I'll show some testimonials, you're going to be a satisfied provider as well, and we have ample evidence of that. You know, receiving care in the home helps a lot. I mean, the one story I remember, big stroke in Camrose, patient actually has to leave Camrose to Red Deer in the central zone to get the type of rehab they need. Think that once they're going from Red Deer back discharged to home near Camrose, it's all over. Who's going to look after me? And there was the same team that had looked after them initially when they were admitted in Camrose to greet them at the door. And from the clinician point of view, the quadruple aim, again, we want to know that we're doing a good job. We often don't do it or know it because we're in the trenches buried, but we were able to provide this. And so providing this sort of care in a patient's home, being part of the family, makes a tremendous difference. So prior to stroke action plan, the stroke unit care was provided only in Edmonton and Calgary. Outstanding results, leadership for the country, no question about that. People like Mike Hill, Andrew Demchuk, Tom Drakathil. Tom was the medical director, and I have to acknowledge the expertise and the leadership in time that he did not have that he provided to us. Just amazing. Oh, Tom, you're here. And after stroke action plan, I mean, Alberta is a big province, but, you know, and then you look at the radius of the early supported discharge, we have touched a lot of patients. There's no question. We have made a big difference, which is what we set out to do. Lots of good press on it, but it's not why you do it, but it's nice when it is acknowledged. And then since Stroke Action Plan, well, I think this project is its natural successor, and kudos to all of you. I think the other advantage of SCNs, Mike and I went for the reverse site visit, arm in arm, to make the case for QuiCR, and we were going to be the knowledge translation unit within the health system. It made tremendous sense, and it would continue on the work of Stroke Action Plan. So QuiCR is the natural extension. Escape, as I said, a happy side effect that's proven the role that endovascular recanalization, where it's available, where you can get a patient to a stroke cath lab and fish out that clot, makes a tremendous difference. And in fact, having the network again helps expand that through the province, getting the resources that are necessary. And the other benefit of cardiovascular health and stroke being together, as I often said when I was a senior medical director, we learned about aspirin from stroke neurologists. They showed us if it works for stroke, maybe it'll work for mini heart attacks, and 50% mortality reduction in mini heart attacks. It was the first thing. For pennies a day, we could change the outcome. So everybody has something to learn. Everybody has something to teach. In cardiology, we went on to build cath labs, primary angioplasty centers. So the systems of care that stroke need to evolve is going to be accelerated because we have that sort of thinking, we have those sort of systems of care already built up, and we are happy to piggyback those. So again, I think it's been a very happy marriage indeed. Another, poor Ashfaq Schwabe has been advancing the idea of a stroke ambulance. In cardiology, we're so lucky. Our tool to say whether you're having a heart attack or not is a simple ECG invented in 1917. Anybody can apply the leads. Anybody virtually can read them or be taught to read them in no sense. So we know when you need to go to a cath lab. You need a CAT scan, and that's the difficulty. So you got to go to a CAT scan center. If you're thinking about endovascular recanalization and you want to do an angio, that's not available 24/7 in a lot of centers. So we've got to figure out how to direct you. Well, if we can bring the CT scanner to you in a stroke ambulance, then we can at least cut time off. Minutes counts, brain counts. Time is brain. And so the stroke ambulance project, I'm really looking forward to following. It's taken a long time to get it there, but it will be happening in a pilot project here in northern Alberta between Edmonton and Camrose. Endovascular recanalization, again, related to the ESCAPE trial. Well, we have to figure out how to put it into the system. Calgary has led the country with the first Stroke Distinction Award from Accreditation Canada. It's the highest award that you can receive from Accreditation Canada. And so we're working to getting that for the Edmonton zone, indeed for the whole province, because we want to be at that level of stroke care that Accreditation Canada recognizes in the whole province, not just in portions of it. So the lessons learned, again, I think the strategic clinical network in this particular case, cardiovascular health and stroke and cardiovascular health, has been effective at accelerating and improving stroke care in this province. I think we are definitely international leaders, not even just national leaders. Cardiovascular and stroke have been and will continue to be synergistic. We've seen best practices scaled and spread. We've seen best practices, the next best practices demonstrated in this province. And I really think it shows the benefit of taking advantage of two phenomenal medical faculties, University of Calgary, University of Alberta, leveraging that research community, bringing it together to improve the quality of care. And it's been an amazing journey, and it continues to evolve. Thank you very much.